Hello everyone. Today we're continuing with the uh, geriatric rheumatology. So last time we have done two topics. Not two. I've done metabolic bone disease. 2-3 topics in there. Here today I'll be doing the proper uh, rheumatology. And in proper rheumatology, we have got osteoarthritis. Then there is the crystal-induced arthropathy like gout. Then there is an inflammatory myopathy. It's called polymyalgia rheumatica. Seen exclusively in people after 65 years. All these things are seen mainly in old people, including the one rheumatoid arthritis, the next one. Lastly, we do spondyloarthropathies. Spondyloarthropathies probably it has got a younger population also, though older people will have continuation of that illness. So coming to osteoarthritis. Osteoarthritis is one which all of us suffer from generally, and now people most of that affection is in the knee joints, what we see in our clinical practice. And the next one probably is in the hands. People are not able to, they got lots of hand. The distal interphalangeal joints are the ones. Now this talk is meant for medical fraternity, but I'll try to make it as palatable to the general population also. So, or I make it simpler so others can also understand that. So, distal interphalangeal joint means the three phalangeal joints are there. The joint at the terminal part, it's called distal. That is the area where osteoarthritis usually affects. Though it's not a dictum, it can affect a proximal also. But there is a criteria that it should not affect more than 3. This joint, this metacarpus, that is the bone just before the finger starts, that bone, and there is a joint there, metacarpophalangeal joint. That joint, more than 3 should not be affected. That's one criteria for osteoarthritis, because that joint is predominantly affected by rheumatoid arthritis. Proximal metacarpophalangeal joint, as well as the carpal joints and all. But carpal joints can be affected. Carpal means where the hand joins with the forearm. It's the joint here. The carpal joint is here. Carpal joint, no? Here. Carpal joint. The 10 bones are there. 10 or 9. I know 9. I don't know. we usually go by mnemonic, which I cannot say. That but several bones are there, around 10 bones are there. Okay, I don't want to remember that mnemonic in any case. Both the hands of that joint that can be affected by osteoarthritis. So people are not able to work properly, becomes stiffness. Stiffness is the main thing in the hands, whereas pain is main in the hip and the knee joint, ankle and foot joints also. So these are the areas where osteoarthritis come. Mainly it is a knee joint. So in knee joint you can get this thing if you palpate the knee. Palpate means if you press on the knee, the bony part of the knee can have some pain. Pain will be there. Then in between the bone there is something called synovium. In some conditions like rheumatoid arthritis, synovial bulge. But that should not be there. That tenderness should not be there. Then the diagnostic criterion is not filled. So that should not be there. Then if you take an X-ray, you see mainly in the hip, you will see that there is a decrease in the joint space between the two bones. That is called a loss. That is loss means L is for loss of joint space. S for what's called a subchondral. Subchondral means this I said there is something in between the joints called the synovium, but the synovium is only a lining. just behind the synovium, between the bone and the synovium, there is a part called cartilage. The cartilage is the place where osteoarthritis pathology takes place. So in the cartilage, the cells are there. They are called chondrocytes. Chondrocytes become old. That's supposed to be the mechanism. The cartilage repair is not taking place. And it is also theorized that not only that cartilage, but even the bone just behind the cartilage will also send signals to the damaged cartilage. Once the cartilage is damaged, what happens is the osteocytes in the bone. Osteocyte means cell in the bone, just behind the cartilage, will send signal to the cartilage to make bone there. Then you get what's called a subchondral sclerosis, not so we can also say subchondral calcification, but it's generally called sclerosis by convention. Sclerosis in other parts called it's fibrosis, fibrous tissue, but here it is the bone tissue. So subchondral sclerosis means bone formation in the cartilage. The cartilage itself can get converted to bone. Before bone formation, this blood vessel has to come in. The blood vessel come in, and some nervous tissue will also come in. That's why pain. Lot of pain will be there. The pain will be usually when you are walking, when you are doing something. It is something like this. Early morning when you wake up, you will have difficulty with pain in the foot and pain in the ankle, pain in the knee joint, pain in the hip, difficult to sit up for a short duration of time, less than 30 minutes usually, maybe up to 1 hour, less than 30 minutes, the usual. It's called morning stiffness. Morning stiffness is a paradigm for all the rheumatological diseases. Morning stiffness that happens in rheumatoid arthritis also, but the duration is more. It's more than 1 hour in rheumatoid arthritis. But here it should be, by criterion, it should be less than 30 minutes. So that is osteoarthritis. And pain is the main thing. Pain after work you will get pain when you're walking. Usually it will be after work or after exertion initially, but later on the pain will become prolonged. They become day long and even night long. So the night long means people cannot sleep. It becomes a real difficult thing. That's why people go for all the drastic treatment, But treatment is again analgesics, and the analgesic choice I cannot say that is choice, but you can try opioids. Opioids means the group of drugs of this nature, the tramadol and all those things, tramadol. Then what is the other oral? Tramadol is about the only oral opioid nowadays available. The oral morphine is not given for this. That's given for terminal stage of malignancy. It's not available. Oral morphine is not available. We used to get this one Proxivod and all that, but after this one opioid epidemic in the US, the companies have stopped. There was an oxycodone. This one, the scandal was there. There is something called oxycontin. It is supposed to be more stronger than tramadol. So people started taking it, and a lot of people became addicted to it, and a lot of people died. So the company had to face face the music. They are taken for litigation and pay a lot of money, sell out a lot of money. But now what the last week the court in the US declared them to be what is that? They become paupers. That pauper means they can keep some money, something like that. So it is in favor actually. When you are pauper means it's called they call it technical term is bankrupt. I think if you become bankrupt, then you get some money. So that's a way to save an industrialist. So anyway, the opioid is available. This tramadol, paracetamol is there. Paracetamol is you can try, but not much side effect. I'm talking about the drug which you can give, which is side effect. It's called non-steroidal anti-inflammatory drug. That's a class of drugs. The people here in our country more familiar with drugs like Brufen and all those things. But there is a drug called naproxen. Naprin and by the many brand names. Naproxen is supposed to have less cardiovascular side effect. because if you give NSAID to people having heart problem, it can induce cardiac ischemia. It can as well aggravate cardiac failure because of its action on the kidney and because of fluid overload and all those things. It produces fluid overload in the body. That's why if you take NSAID, you get some edema. The same mechanism will aggravate cardiac failure. So it's not recommended people having all this kidney disease, liver disease. It can produce kidney disease also by its anti prostaglandin effect. So NSAID is a drug, but people having a lot of pain. What else can you give? You give NSAID. Give naproxen if possible. Naproxen, 500 milligram BD. I'm talking to the people who give it, the doctors, give naproxen if possible. But the other drugs are coming up, like it's all an experimental stage. You can give this one phosphonate drug, because there is an element of osteoporosis also. This osteoclasts also go into in a wacky state. So you can give the same bisphosphonate drug, alendronate, that is zoledronate, that group drug. But it's in, I think, still in experimental stage. Another experimental treatment is methotrexate. Methotrexate is an anti-inflammatory drug generally given for rheumatoid arthritis, synovitis. But this is also, even though we say that if inflammation, it's not osteoarthritis, there is some element of this one. What is that? Synovitis. There's an element of synovitis in osteoarthritis. That's why sometimes you get night pain, severe night pain. So in such cases, people give methotrexate, but the trial is ongoing. It will be finished at the end of this year, so then you can give. But nowadays the beacon is the shining beacon is, or the standard is nowadays knee joint replacement. Lot of disability, lot of pain. You can give this thing, but it is a lifespan, that knee joint replacement, maybe maximum 20 years, not more than that, maybe less than that. But so better to give to people knee joint replacement after 60 years. Before that, please don't try knee joint replacement. Now it's become commercialized and all that thing, but it's your duty to protect the patient. That's the last option actually. That's about osteoarthritis. Then the osteoarthritis, clinically, I just go on to that also. There is one type called generalized osteoarthritis. Generalized means it will affect the finger joints, at least other two joints. That is generalized osteoarthritis. Then there is rapidly progressive osteoarthritis. That mainly affects the hips of, mainly in the females, hips. It comes just like septic arthritis, so very, very fast. Very severe, the joint destruction. So rapidly acting osteoarthritis, that is one variant. So that will help you in diagnosis. Then there is this one, something called inflammatory arthritis, like presentation. All the fingers of the joints will have. Actually, that is because of crystal deposit. It is actually something like the urate deposition. Here in urate deposition, it is the monosodium urate, and here it is a calcium. There is calcium phosphate, but what calcium phosphate? Calcium pyrophosphate. Pyro is burned. It's supposed to burn and become calcium pyrophosphate. So calcium pyrophosphate deposition in small joints causes inflammatory arthropathy of osteo. It's a misnomer. Inflammatory arthropathy of osteoarthritis. But this happens in some people, So it's a differential diagnosis. You have to make a differential diagnosis with the rheumatoid arthritis. So rheumatoid arthritis means if you test, inflammatory mediators will be high, like CRP will be high, ESR will be high. Then there are some other criteria also in this one, rheumatoid arthritis. You will get RF factor positive. Then there is something called cyclic citrullinate peptide. That is a peptide inside the synovium. That's an antigen. Against that, the antibody is supposed to act. That's a pathology, rheumatoid arthritis. So all these things will be there. But in inflammatory arthritis, it's crystal induced, calcium pyrophosphate. So gouty arthropathy is urate arthropathy, but it is mostly monoarticular. But in old people, there's a difference. In old people, they can get polyarthritis with the gout. They can get shoulder arthritis and other places, knee joint arthritis and all those things. And but sometimes they will give a history of what is called gout. Generally, when we studied in MBBS and all those things, they used to say podagra. Podagra is a term for this gouty arthritis of a joint between it's called a metatarsophalangeal joint. That is the foot joint. The finger joining up with the foot. That area is metatarsophalangeal joint. that joint action, that's called podagra. Sometimes you can get a gouty tophi also. So the diagnostic criteria is this one, gouty tophi. Then if you aspirate knee joint, you can get this one, sodium monourate crystals can be seen under the microscope. So this is the thing. And serum uric acid can be measured, but 90% of the people having a high uric acid level, they may not have symptoms, they need no treatment. Only when they become symptomatic with the thing gout, you have to treat them with what is called xanthine. Xanthine is a precursor of urate. So xanthine oxidase inhibitors. There are two drugs are there. Mainly we used to give what is called allopurinol. Allopurinol. It's about 100 milligrams daily. Give it a small doses because it can induce sometimes a severe reaction. Rarely, I have not seen just read in the textbook that it produces a lot of allergic reaction. It's called it can produce hepatitis, dermatitis, and also kidney failure finally. So careful with this one. Give a small dose. 100 milligrams is enough for the same allopurinol. But they also say about colchicine is supposed to be the drug of choice. Colchicine, I have no idea. I think it's available. Some people are using it. The dosage should be very small. Again, very toxic drug. 2.5 milligrams is enough. But the safer alternative new drug is called febuxostat. Again, this is xanthine oxidase inhibitor. So it can be given in 40 milligram or 80 milligram dose. So that's about the thing. Gout and inflammatory arthropathy. So I just finish up the inflammatory myopathy also, which is called polymyalgia rheumatica, exclusively in people after 65 years. The importance is, so it will come with pain in the shoulder, pain in the hip, then it will have all the inflammatory parameters will be there. And then another thing is creatine kinase will be negative because the differential diagnosis is polymyositis. Same thing, same presentation, pain, difficulty getting up, walking, and all those things. But polymyositis, dermatomyositis, this one creatinine kinase will be very high. Here creatinine kinase will be normal. Creatinine kinase, the muscle enzyme, will be normal because muscle destruction is not taking place. It is an autoimmune disease, but the importance is this is associated with temporal arthritis. Temporal arthritis, otherwise called giant cell arthritis, because of its pathology, giant cells are there. Giant cell arthritis can lead to blindness. So there lies the importance of diagnosing polymyalgia rheumatica in people after 65 years, because somebody gets this about less than 10%. They say 1%, 2%, I don't know what percentage. Maybe a little less than 10% can have temporal arthritis. So you have to exclude temporal arthritis in people having polymyalgia rheumatica. And the only way to exclude that is taking a biopsy. But a biopsy is the definite thing. Take a long biopsy. In some area they will get the giant cell arthritis. That is and the treatment. Actually, with one criteria for diagnosis is the response steroid. It responds dramatically to steroids. So polymyalgia rheumatica. That's the same treatment for temporal arthritis also. But in temporal arthritis, the dosage is higher, full dosage, 1 milligram per kilogram of prednisolone. Here in polymyalgia, you can give a small dosage and treat it for maybe 2 years, 3 years, then taper it. And if there is no response, people give disease-modifying rheumatic drugs, anti-rheumatic drugs, methotrexate also, I think. But it's all off the label. And coming on to this one, rheumatoid arthritis, I already gone into pathology. Rheumatoid arthritis pathology is in the synovium. It's a synovial disease. Synovium becomes aggressive. Synovium is the one which attacks the bone, and in turn the synovium gets attacked by the bone and becomes what's called subchondral sclerosis. It gets subchondral sclerosis, and so so the severe derangement of the joint will take place. Mainly it affects the small joints. It can affect large joints like the knees also. Mainly affects small joints, proximal interphalangeal joints, metacarpophalangeal joints. I said previously. I said so. These are pain, night pain, then extra-articular manifestations like fever. Sometimes some people get uveitis, things like that. The autoimmune pathology is there. And diagnosis is by, I already said, rheumatoid factor. Rheumatoid factor is nothing but immunoglobulin against immunoglobulin. That is antibody against antibody. Antibody is involved in the pathology of this joint arthropathy. Here, our IgG is involved in here, and B cells are involved here. That's why sometimes we give B cell monoclonal antibodies as treatment, monoclonal drugs as treatment, biological treatment. That's the latest treatment, but very expensive, not possible in our country. But mainly we will depend on methotrexate. And give it to the rheumatologist. If you think that this is rheumatoid arthritis, give it to rheumatologist, because they are the experts in giving these kind of disease-modifying anti-rheumatological drugs like methotrexate and other things also. Methotrexate is the main drug for this. Not cyclophosphamide. What is that? Other less toxic drugs are there. But methotrexate is the least toxic of the lot. So methotrexate can be given in a small dosage combined with our old anti-malarial hydroxychloroquine. Hydroxychloroquine can be given anywhere. Even osteoarthritis, if you think can need some synovial treatment, anti-synovial treatment, put them on. By all means, put them on hydroxychloroquine. Not very toxic, very very rare ophthalmic toxicity, very very rare. So it's quite safe. You can put them on 4 milligram of hydroxychloroquine. Here also, combine of these 3 drugs, corticosteroid. That's one area where you can give for rheumatoid arthritis. Small dose. So all this cocktail of drugs, small doses together, will give them good relief. And then put them in remission. And nowadays we don't see all the sequelae of rheumatoid arthritis like Z deformity of the thing, big toe, Z deformity. It becomes like a Z, because even the metatarsophalangeal joint here dislocates. Then swan neck and ulnar deviation like this. Hand will go like this. People cannot do anything. Life becomes hell. That's why this nowadays people go for treatment and they get good relief also. And so kudos to them. And then the last part of this thing is what's called spondyloarthropathies. Spondyloarthropathies. Spondyle means the ligaments and the soft tissue near the joint is called spondylo. And I don't know if it's particularly referring to the intervertebral, the cushions. But anyway, that also includes spondylo. So spondyloarthropathy means one specific spondyloarthritis is there, which is associated with our HLA, HLA B27. That is the one which is, we have seen the picture, the bamboo spine. That is the intervertebral spaces become calcified. that is one arthropathy, but in the criteria they say that it should have some peripheral arthropathy, but this body ankylosis is not specific to this disorder. It can happen in this one, what is that, a bamboo spine disease, but it can have a peripheral bone ankylosis means the bone joint will get destroyed, it will become bones will touch together. Because bamboo spine means there is no intervertebral space, it's all calcified. That's a bamboo spine, you get the bamboo spine. Then another criteria for that is that you should have the inflammatory CRP should be high, things like that. So what's the treatment? Again, a monoclonal antibody for it. Mainly the TNF alpha TNF alpha is the cytokine for destruction of the thing, antigen antibody reaction in the joint. So that is the best treatment for the thing, the spondylosis. Not spondylosis, what is that? Some name is there for the bamboo spine. That is because it's a severe disease, people, if you don't treat it, people will have to walk like that, they cannot bend. So treat them with a monoclonal antibody if possible. That's supposed to be the treatment of choice nowadays. Otherwise, all the NSAIDs you can manage with that. And I am not going into the details of this treatment. But along with spondyloarthropathy also includes psoriatic arthritis, and also some non-specific arthritis there, like arthritis associated with gastrointestinal, inflammatory bowel disease, and things like that. In such cases, but this is also supposed to be a criterion for spondyloarthropathy, that you will have extraarticular manifestations. So that's how you make a diagnosis of spondyloarthropathy from rheumatoid arthritis and other things. And the treatment I have just mentioned, anti-inflammatory drugs, analgesics, and monoclonal antibody is nowadays supposed to be the drug of choice for this group of drugs. But this one, psoriatic arthritis, probably will have to give high dose of steroids, highly inflammatory, with psoriasis. Sometimes you have to treat like rheumatoid arthritis. So thank you very much for the listening. Hope it's a small video. The whole rheumatology, this geriatric rheumatology, just pass through. Any questions, queries, or doubts or whatever, you can communicate to me in the YouTube section there. If anybody of you want to get, many of my friends have my number, you can also get my number. Thank you very much.